Mountain Dew. Trying to get us some more money.
Right, we're almost live, and we should be live right now on Facebook. All right, let's see. We've got enough joining us here. Hi, everybody. Thank you for joining us virtually. We're excited to be doing another Ask the Hematologist. It seems like these have been very successful and very well received, so we're excited to do that. If we just want to go ahead and have the physicians introduce themselves and explain what institution you're from, and if you'd like to say anything else, that would be great. So go ahead, whoever wants to start.
Well, I guess I'll start since I'm at the top, though we'll work around. I'm Spiro Catalan from Ohio State University. I'm a hematologist, and I'm happy to be here tonight with everybody and my colleagues here from our consortium.
I'll go next. I'm Eric Parnes. I am an adult hematologist in Boston at Harvard Medical School, Brigham and Women's Hospital. And this is my first time joining the team to do one of these live events. I'm pretty excited.
I'll jump in next. I'm Marshall Mazepa from the University of Minnesota. And I'm an adult hematologist here, and Dr. Cataland and I formed the USTMA now, I think almost 7 years ago. So it's been a lot of fun organizing folks here.
I'm Mira Sridharan. I'm an adult hematologist at Rochester, Minnesota and Mayo Clinic. And this is also my first time doing one of these, so very excited about it.
All right, I guess it's my turn. I'm Metjian, an adult benign hematologist in Denver at the University of Colorado. And I've had an active interest in T2 for quite some time. And this is, I think, my second time doing Ask the Hematologist.
All right, so let's start out with the first and burning topic, vaccines for TTP patients. Would you recommend vaccines in general because they activate the immune system? Patients are worried that if their immune system gets activated, it risks a relapse. And then moving on to the more specific question is, are COVID vaccines safe for TTP patients, and how would you recommend they go forward receiving them?
Eric, why don't you take this one?
Sure. The answer is yes, get the vaccine. That's the only way we're going to get out of this mess. COVID is a very dangerous infection. We know, all of us know firsthand because our hospitals have been packed and we've seen a lot of very sick people. And fortunately, we have a way of getting past that, and that's through vaccination and hopefully eventually herd immunity. I know taking the vaccine generally is well tolerated by people, but also side effects are common. I know my personal experience was I was feeling achy and feverish for a day or two after my second dose. So you can expect some side effects like that. You don't have to worry about having a TTP relapse. That is such an unlikely event that the benefits, I think, far outweigh that kind of risk. There are some reports of people having a relapse or a new TTP after getting vaccination. There's one publication out of Italy that I found, and I personally have a patient who got a vaccination for COVID and then had a relapse, but that was someone who has relapsed several times. But when you look at the numbers and recognize that over 1 billion doses of vaccine have been administered worldwide, those exceptional cases, I think, are likely to be coincidental.
I agree with you, Eric. There's this theoretical risk of any autoimmune disease that could be activated or flared by a vaccine. And there's always that risk we talk about of could it lead to an acute TTP episode? But you have to also think about a COVID infection could do that same thing. And dealing with COVID and a TTP flare is certainly not what you want to be doing. So there's really not a lot of reasons not to get the vaccine. It really doesn't make sense. It really does.
Would you guys recommend one vaccine versus the other, or would it be, or would it not particularly matter? Or are the mRNA vaccines with the 2 doses a higher risk for TTP patients, or have you not really seen that?
I think we don't know the answer quite yet, but you know, certainly there was a lot of press with the halting of the Johnson and Johnson vaccine in the U.S. Due to a disease that sounds similar to TTP. It's a different immune disorder where the platelet count goes low and large blood clots form that I think we're still trying to understand. And thankfully is exceedingly rare, but was obviously a good reason to pause vaccination for the FDA to review things. You know, so I think that the 2 mRNA vaccines are the vaccines that at this point my patients have been vaccinated with and have done well. I have had these conversations with many of my patients, and we generally talk about what are the risks of the vaccine, and I think these are more theoretical risks so far that we've seen, and obviously the clear benefits that Dr. Parnes mentioned. So, you know, together I feel like we've come down the side that the vaccination is an important part of trying to move beyond this disease, and that the risks of COVID compared with the risks of a TTP relapse clearly favor vaccination over the risk of actually getting the disease.
Hey, we can throw a plug into one of our colleagues, Marie Scully. She's actually the investigator in London who actually was the first to find or discover or report, diagnose this rare reaction. It was to the AstraZeneca vaccine and something similar with the Johnson & Johnson. But like Marshall said, and Eric, these are winning the lottery type of rare reactions that we're just seeing as millions and millions of people have gotten each vaccine. So those are marked exceptions to the rule.
It's also worth pointing out that the mechanism is different than TTP. Yes. So they found in the Dr. Scully's group found in those cases the PF4 antibody, which we see with heparin reactions on occasion. So it's not driven by ADAM-TS13 like TTP is.
Great. So just to summarize, it's safe for TTP patients and recommended for TTP patients to get the vaccine. And this thrombosis that you're seeing patients very rarely develop is not TTP. It is something that is creating clots also, but it's not TTP. It wouldn't be acquired TTP being triggered in patients. Okay. Is there any testing that you guys would recommend patients get before they get a vaccine? Should they have their ADAMS-TS13 tested, or do you think if they're safe or if they're in remission and they're asymptomatic, that it's safe for them to go forward as long as they follow their hematologist regularly?
I think if you're getting your ADAM-TS13 monitored regularly with your hematologist, you can rely on some previous readings, I think, to guide that. But to tell people to get your ADAM-TS13 tested before you get vaccinated, I think is a bit much. I wouldn't recommend that. But it's something to talk about with your hematologist.
Yeah, and so at Mayo, we haven't been routinely checking the ADAM-TS13 prior to vaccination, but one of the things that we've instituted doing mainly just to see what the incidence of these side effects are is we've recommended checking the CBC weekly for 4 weeks after the vaccine, just to ensure that we catch any type of thrombocytopenia, whether that's immune or non-immune, after a vaccine. And this is more to get a better idea of what the incidence of these episodes are. In a way, it is also kind of protective for our patients that we know have an immune-mediated disorder to be able to catch something early on if necessary.
Okay. And with that, one of the questions that was submitted ahead of time is asking if there's a new protocol being observed in emergency rooms for patients with thrombocytopenia or low platelets due to this new awareness that may be a reaction to the COVID vaccine, and if that may actually end up helping TTP patients who are having an episode or will be newly diagnosed in a faster manner. Are you guys aware of any change in ED protocols?
So not necessarily a protocol specific for a TTP patient, but we do have a recognized awareness of, again, this very low incidence of this thrombotic thrombocytopenia that's happening with certain COVID-19 vaccines. And so we have provided our ER physicians and even some of our outpatient physicians some templates to follow if they see a patient with new thrombocytopenia and or new thrombosis after receiving a COVID-19 vaccination.
Okay. And here are kind of two questions I think are going to go together. The first one has to deal with preventative measures or medications for congenital TTP. As you know, it is different from acquired TTP. If somebody just wants to briefly give a description of the difference between the two. And then are you aware of any treatments or preventative measures for congenital TTP? I'm thinking of the recombinant trials, which is why the next question after that will go with it. So somebody just wants to give a description between the two and then speak to if there's any treatments or preventions for congenital TTP relapse.
I can take this one.
Go for it, Aaron.
So with immune TTP, that's probably the most common one. Someone they're born with, they have ADAMTS13 activity levels that are well within normal limits. But for some reason, there is a breakdown in the immune system and an antibody or an immune response is made against that antibody. And one of the ways to treat immune TTP is by giving immune suppression, steroids, medications like rituximab, in order to blunt and dampen or remove that immune system, that immune response against ADAMTS13. In contrast, patients who have congenital TTP are those that are born without ADAMTS13. And for them, the use of immune suppression is not going to be effective because this is not an immune response. And then I believe the second part of the question, Claire, jump in if I'm wrong, is what are the preventive medications that are available?
Yes.
Classically, or typically, that has been either infusions with plasma at some regular basis for patients who've needed it, whether it's once a week, once every 2 weeks, once a month. And unlike the data that's available for hemophilia, where there's data to suggest to do it early on within the disease before the third bleeding episodes, at some variable point in time, there is the regular infusion of plasma. Another agent that has been used are, again, borrowed from the realm of hemophilia, which are what are called low purity factor VIII preparations. And that means not in terms of their dirty products, but just they're not 100% pure for factor VIII, which is what's used for hemophilia. And some of these plasma-derived products that are used in hemophilia are enriched or have very high levels of ADAMTS13 within them. And so those are the two broad categories of preventative medications that are available. Now, for those people who've looked around, there is a recombinant ADAMTS13 that is currently in clinical trials. Definitely at institutions that are participants within the USTMA. And the COVID pandemic definitely put a crimp in the current progress of those trials, but they are still up and running. Did that answer the question?
Yeah, so this recombinant ADAMTS13 would essentially replace what the patients would be lacking in congenital. And the idea is to overwhelm the antibody for the acquired, correct? Just to give a quick summary.
Yes. So for congenital, this would replace, and the hope right? That's why the reason we're doing the clinical trial. The hypothesis is that regular infusions of recombinant ADAM-TS13 will replace exactly what is missing and will prevent any relapses of TTP. And in immune TTP, this would be used as an adjunctive therapy while the patient is in an acute episode of TTP.
So another popular question for preventing relapse for patients is the use of Rituxan. So the question is, how frequently do you suggest a patient gets Rituxan? And if a patient has received Rituxan and they have low B cells, will that change the efficacy of the vaccines, of COVID vaccines or any other vaccine going on? So what's your treatment plan with Rituxan? Do you utilize it, and will it affect vaccine efficacy?
Marshall, you've been knee deep in rituximab with your paper and your study. Why don't you
Sure.
give this one a shot?
Yeah, and this is a conversation we're frequently having with our patients here, not only in TTP, but in other immune diseases. And I think doctors in other specialties struggle with the same issue. I think, first of all, during COVID, we've avoided medicines to suppress the immune system when we could, because we know that immune suppression is a risk factor for severe COVID. It doesn't mean that it happens to everyone, but it is a potential risk factor for the more severe form of the disease. So we've tried to avoid these medicines when we can, but there are times when we can't. And then with the vaccine question, we know from papers many years ago that rituximab blunts the reaction to other vaccines for up to a year. And that varies from person to person. And part of that is because, interestingly, the drug has different effects in different people. And it seems to last longer in some than in others. So we can take what we know about other vaccines to estimate what would happen with the COVID vaccine. And I think it's probably a good guess that if you got rituximab within the last 12 months, that your response to the vaccine is possibly lower, but maybe not. I think we just don't know. So my personal approach has been to say, if we can get you the vaccine before rituximab, that would be ideal. But there are certainly circumstances where the risk of holding off on rituximab is too high. And so we would give the drug and then wait to vaccinate until later. But it's all about weighing what are the risks of each, whether the risks of the vaccine, risks of rituximab, those sorts of things.
There are, rituximab is used in so many different diseases, not just TTP, and there's lots of people who require maintenance dosing. So, they could be on it for life even. And it's hard to find the right time to get people properly vaccinated, really, for any disease. So our immunology group has recommended trying to time it so you get vaccinated 4 months after your last Rituxan infusion, and that might give you 2 months before your next Rituxan infusion. It's not a perfect world. I think I always try to wait a good 6 months.
But overall, the idea is that the vaccine will help in some way more than not getting it, even if you've received Rituxan.
I think the simple answer, you shouldn't use one or the other as a reason not to do the other. So if you need rituximab, you should get it. If you need the vaccine, you should get it. And if you don't develop a good response to the vaccine because of the rituximab, it's certainly better to try, and we can revaccinate you later, I think. So if you need one or the other, you should get it, and don't outthink yourself on it.
Yeah, and there's protection from others if others in your household have been vaccinated and others in your community are vaccinated. That helps protect you as well. So um, uh, that's another important point.
A distinction might also be that that there's probably no harm in getting the COVID vaccine. But as alluded to, it may not be as effective as if you had not gotten rituximab, but still, whatever benefit someone may get from getting it, even if it's a partial response, is better than getting nothing at all.
Yeah, worst case scenario, it doesn't work. Best case scenario, it does.
Either way, you shouldn't go on a play date with people with COVID.
All right. So here's kind of an interesting question, kind of a fun one. So a patient wrote in that the NIH has committed $1 billion to the study of autoantibodies being created by COVID infections for these so-called long haulers. Do you see any of the outcome of this research having benefit for those with immune TTP, since autoantibodies have been discussed there, against the ADAMTS13?
I think it's always hard to predict what research is going to benefit whom in the future. I think there's a lot of things you learn and you may not find that how applicable it is to any particular disease until maybe a couple years in the future. So everything we learn, whether it's clinical science or some basic science research, may be applicable to some diseases. And I think the more we learn, the better. The more a lot of times what we think we know, we're steered differently by some studies. So more information is good. We'll just have to learn how to apply that in the future.
Okay. Now here's another hot topic, Capitalism. How are you utilizing it? How do you think it'll change the landscape of acquired TTP? And if somebody wants to give just a quick layman's overview of what the medication is and how it functions, that would be great.
Well, why don't I give the overview and then I'll let others talk a little bit about this medicine. And so this was a medication that's a new class and sort of a new family of medicines. It's engineered protein. So it's like rituximab in that it is a protein that's targeting a specific target. But it's different than rituximab in many ways. First is that it does not affect the immune system and is also missing a piece of the antibody that makes it last longer in the blood. So capitalizumab doesn't last much more than a day in the body and does not affect the immune system. But what it does is stick to von Willebrand factor, which is a big sticky protein in TTP that causes the platelets to clump together and form tiny clots. So 2 large studies showed that giving this medicine in addition to plasma exchange shortened people's hospital stays overall. The second thing that was found was that while you take the medicine, you're protected from the disease coming back. No drug is perfect, so there were a few people who had recurrences, but far fewer than with plasma exchange alone. There were no people who had refractory disease, meaning that we couldn't get the platelet count to rise with plasma exchange or during the hospital stay, which happens infrequently, but is a bad problem with TTP. And more recently, when the 2 trials were combined together, researchers found that there was a reduction in deaths from TTP, which is, I think, an important finding that has only recently come out because the data from the 2 studies were combined together. Thankfully, death from TTP is not a common event, but no patients died who got capitalizumab in the 2 trials combined. So that's kind of the 30,000-foot overview. The medicine is now FDA approved, and it is, I would say, variably available across the country. So experiences, I think, are still pretty new with the medicine.
I used it for the first time last month, and it was a great success. It took a lot of effort to get our hospital system to approve that. There are some studies showing that it is cost effective and it's not cost effective, and it is very expensive. So I think there, as Marshall said, not everybody has access to this medication.
Do you guys, what are some of the side effects of Capitalism? It's a question that came in. And that's kind of interesting in the mechanism as well.
The biggest, I can answer this one. The biggest side effect is one of bleeding. By the way Capitalism works is by blocking that normal interaction between platelets and von Willebrand factor, both are which our body uses to clot the blood. And when that is interfered with, there's an increased risk of bleeding. Most of the bleeding that was seen within the clinical trials were generally what we would consider rather mild. There were no limb or life-threatening bleeding, and it's limited to things like nosebleeds. Or for someone who is getting this around the time of their menstrual cycle, this will invariably lead to a heavier period. But that is the biggest one, is bleeding. And of course, there's going to be the side effects. Since this is an injectable medication, there'll be the local site reactions. Aside from that, there were no other brain, heart, lung, liver, kidney, side effects that were associated with it.
No, I agree. I mean, what you're doing is trading a mild bleeding picture for a much more severe clotting or thrombotic picture, which is what TTP is. So you've always got to look at both sides of it. So on balance, it's quite effective, and I'd say quite safe.
It's considered part of our go-to. Just like we would start plasma exchange and hydrosteroids, and now with rituximab, the use of Capitalism up front, that should be the cornerstone of the treatment of TTP.
Yep, I would agree. I think the two things that nobody will argue with is it is very effective and it is very expensive. And that's the balance of hospital systems. And to help patients understand, when things are prescribed as an outpatient, they get paid for by insurance typically. When they're prescribed as an inpatient, there's sometimes a lump sum payment that hospitals get to cover all the expense of the entire hospitalization. And a very expensive drug could eat that up completely. So it's really the inpatient dosing which has caused the issues. And as Marshall and Era said, the availability, where it may be available in some hospitals and not the others. But everyone's working on that, trying to increase access to it.
And I think it's probably worth mentioning that several of us were involved in the trials and have worked with the drug company while it was getting FDA approval. So we should disclose those things. On the other hand, the data certainly indicate that the medicine is helpful. I think what has been debated is more about, is the cost of the medication worth the interval benefit? And I think, to me, seeing that patients, even though dying from TTP is very rare, exciting to see a medication that reduced that. And some of these very troublesome but uncommon complications, having a hard time getting people out of the hospital and such, are also important, I think, quality of life factors and as well. So probably the most important thing to say from the sort of conflict of interest standpoint is that the International Society on Thrombosis and Hemostasis has issued guidance, including experts from around the world, indicating that in many circumstances the medicine should be used, but of course with careful judgment. So even though many of us are conflicted in terms of working with the company, I think there's acceptance of the medicine, just struggle with costs.
Oh, it's important to mention that we were all involved in the studies, but I'll also give our consortium a pat on the back because I think our consortium sites, I think, Marsh, weren't we responsible for close to a half or 2/3 of the patients in the US on the study?
Yeah, 85% of the patients were seen at our centers.
So if we're going to pat
Most of those
ourselves
were
on the
Dr.
back.
Metjian's patients. he's put a lot of work and effort into bringing that.
But really, it's
work.
really why we put this consortium together. And it's nice to see we're able to do what we tried to set out to do, which is help collaborate on research.
All right. So a couple of questions about diet. Are there foods that you guys are aware of that would raise a platelet count, or foods that you would avoid if your platelet count was low or your ABS-TS13 was low? And then kind of following from that, what are some triggers for a relapse that you guys have noticed, and who wants to talk about that two-hit theory where there's two components for a relapse, not just the one?
Who wants to take a shot? Go for it, Eric.
I'll take a shot. I'm going to take the easy approach. Probably what you should not take. I think no one here would say take if you have quinine or double down on the tonic water. That's probably the easiest and safest and my coward's way out from answering the question. Just because there are rare reactions where people's platelet count can suddenly plummet after taking quinine or quinidine. Whether it's taken for it's grandma's medication for leg cramps or because we want to avoid COVID. That's probably the easiest answer. As for any, I would say generally, just based upon just based upon the training that we've had and the experience we've been in, I tend to shy away from supplements that we can't sort of vouch for, because you never know what they may be adulterated with. That is just something that I've just seen with patients who've had other problems that have been related to their blood, whether it's white cells, red cells, or platelets, aside from TTP. But I am not aware of any food or medication or supplements that can be used to augment the platelet counts or to prevent a relapse in TTP. I don't know if anyone else has an opinion.
I completely agree with you, but I'll add in that there are several nutrients that you need in order to make platelets. And if you become deficient in those nutrients, then it's harder to make blood cells in general. Nutrients such as vitamin B12, folic acid, and copper. But if you have adequate levels in those by taking supplements with those nutrients, you're not going to help your platelet count. And most people have adequate vitamin levels. So just taking supplements, as Ara said, is not really going to make a difference for TTP patients.
Just taking a little bit of a different angle from that. So I know the question was specifically about platelets and things to do to improve the platelets. But when I think of TTP, I don't think of it specifically as a kind of just a platelet disorder. Yes, you get thrombocytopenia as a consequence of the disease. But in addition to that, you can have the microthrombosis, you can have the end organ damage. And so when I'm talking to my patients about TTP and things to do to kind of improve their life moving forward, I like to look at them from kind of like the overall patient standpoint and say, okay, what can I do to help you overall reduce your risk in general from having another thrombotic event or a microthrombotic event? And so things from that avenue are just things that your primary care physician may talk to you about in reducing your overall cardiovascular risk. So making sure that your lipids are under control, making sure that your glucoses are controlled and you don't have diabetes, watching your weight, watching your diet. In regards to diet, there's no perfect magic food that's going to make things better, but generally speaking, people advocate for a cardiovascular Mediterranean diet to help kind of lead to a more cardiovascular better risk profile.
Yeah, I think Mir makes an excellent point. There's a focus on the platelet count, and sometimes people think this is a bleeding problem, but the platelets go low because they're forming clots throughout your body. So this is a clotting problem that the platelets get caught up into, and that's an important point to remember. I guess I can talk just real quick about this two-hit hypothesis or two-hit theory. It was first found in animal models where researchers bred mice to not have ADAMTS13 in the hopes that they would develop TTP and you can study the disease in mice. They realized then very quickly that the mice, when they did not have the ADAMTS13, did not automatically get a clinical picture in a mouse that looked like TTP. They had to be sort of provoked to do it. And we've learned in subsequent years the same thing happens with TTP. It's not like you get low ADAMTS13 activity and the relapse happens instantly. We think there has to be something else that happens to sort of trigger that. So it's a triggering event, which can be a pregnancy, it can be an infection, it can be a medication in the patient who already has a pre-existing low ADAMTS13 activity, we think. And one way we know this is an interesting study done from the French group where they looked at women who presented with their first TTP episode when they were pregnant. And they had a remarkably high number, 25%, which is a very huge number for how rare congenital TTP is. So 25% of these women presenting with their first episode actually had congenital TTP. So if you take that back, they've been living their entire life without levels above 10% of the ADAMTS13, but yet didn't get in trouble until that second hit of pregnancy. I think that's a pretty good example of what we're talking about with that. So just low activity doesn't mean you're going to get it. In remission, low activity doesn't mean automatically you're going to relapse, but it does increase the risk for it. And that's part of the discussion.
Would
Yeah,
you say, oh, sorry, go ahead, Mark.
I just was going to mention, I think we all agree that low ADAMTS13 is required to have a TTP episode, but it's not enough all on its own. And as Dr. Cataland mentioned, we see this in our congenital patients that any little illness, stressors, things like that will set off an episode. So it's there all the time, but we certainly see triggers like illness can set off an episode. Of course, sometimes it happens without an obvious trigger. And then we see the same thing in the more common form of the disease, the immune disease, where people can have periods of time with low ADAMTS13, but not relapse. And we often will measure it to try to estimate when a relapse might happen. But I think we use it because it's the only tool we currently have, but it's not a good tool. And that's a major area of work we're doing in our group, because there's a major need to have a better blood test or other tests to help us predict when the disease might come back, so that we can use medicines to prevent it, but cause as little harm as possible, because medicines to suppress the immune system have risk. And obviously this COVID time period in particular brings that to light.
So going forward from that, actually is a great segue into the use of immunosuppression for preventative treatment for relapse. So if the patient were to come into you and they had a low ADAMTS13, would you start them on any sort of medication to prevent a relapse, or would you go with monitoring? And if you did start them on a medication, what is your typical regimen you go towards? And then finally, if somebody just wants to mention about the treatment guidelines that we had published through the USTMA in the past couple of months, and kind of explain why we got together and created those consensus documents.
Who wants to go?
I can give my 2 cents if that's
Good.
okay. I think it definitely helps when you've developed a rapport, a history with a patient, and I would say that if I see a patient who has their inhibitors come back, their ADAMTS13 is starting to drop, at the very least, I think that we all know that that increases their risk of relapse. And since we don't have a good way of knowing what will happen to someone when they relapse from their TTP, at the very least, I'd say, speaking for myself, I'm more aggressive with talking about what do we do next in terms of how do we try to take that inhibitor away, just because we don't know what is going to happen. And I think drawing from what the data that's been published out of France, from the French Thrombotic Microangiopathy Reference Center, where giving preemptive infusions of rituximab were effective when they compared them to a historical control in getting the ADAMTS13 levels to rise back up. The way I approach it is that another 4 infusions of rituximab versus a repeat hospitalization for plasma exchange and high-dose steroids, to me, appears to be the more cost-effective and sort of the better part of the bargain. What does everyone else think?
I agree. I mean, now more so than a couple of years ago, we do have data that suggests that prophylactically treating the ADAMTS13 with immunosuppression does lead to less relapses and hopefully better outcomes. And so our approach in the last several years has also been to use prophylactic rituximab. We have opted to do, rather than using 4 doses, we've opted to do 2 doses of just each a higher dose, but same goal and same outcome. So.
I don't think there's any correct answer. It's an ongoing discussion between you and your physician. But as Aaron Mira said, when you have low ADAMTS13 activity, you are at increased risk. In patients with a prior history of multiple relapses, we may be more inclined to do it and push for it. But at the end of the day, it's really the patient's wishes and what worries them more, getting a prophylactic medication or the risk of a relapse that drives your decision. I would also emphasize that there's a lot of fluctuation if you follow patients long-term in the ADAMTS13 activity. So you want to be aware of a drop, say 80 to 60 or 80 to 50, but you also want to be careful and use the trend more so than one number. And we're still starting to learn about the subtleties of how it changes over time. So use the trend and use it in the context of the individual patient preferences.
Yeah, I think it's important to have the conversation before the test is done. So, a mantra in medicine is to always, before you order a test, know what you're going to do with the results. So I try to have those conversations with patients, and I may have a different opinion than the patient, and that's okay. I think ultimately we try to come together to make a decision. And so if we're going to order the test, we got to know what we're going to do with the results. And maybe that's just we test again in a few weeks, or maybe that's a treatment. And I think it all depends upon the patient's values, the patient's history, and all those things together. Because in the absence of good science, I think we just have to make the best decision we can with the patient.
I have a nice example of exactly what you're getting at. I ordered the ADAMTS13 as a follow-up for a patient in remission, and it actually fell over time and became undetectable. And at that point, I recommended that we repeat a course of rituximab. And the patient was adamant that they didn't want to do it. They wanted, this person wanted to be left alone. So that was fine. That, I'm going to work with them on their whatever their goals are, whatever their wishes are. 2 years later, we still don't have a relapse. He's doing fine. So that brings us back to the 2-hit hypothesis. I don't know what that second hit is, but so far so good.
That's great. And so I know for the acute episodes, high-dose steroids are a typical treatment. Is that something you guys would use as an outpatient preventatively? And how long would you use them for? And what are the risks associated with high-dose steroids?
Steroids are awful. There are so many side effects.
We're all thinking it, Eric.
And I would definitely prefer something like rituximab over steroids. And high dose steroids or long-term chronic use of steroids ultimately is going to lead to so many problems in terms of immunosuppression, weight gain, osteoporosis. The list is long. And then sometimes, adrenal function never really returns. It can be a big issue. For somebody who is kind of needing ongoing treatment, I really try my best to pull away from steroid use.
Yeah, I agree. They can do a lot of good things, but only in the short term. Anything like, when I say short term, I say a couple of weeks, less than 4 weeks. Typically, we try. Steroids are like alcohol, very good in moderation. Too much is not good.
Yeah, the primary benefit is that those medicines work fast, which is different than rituximab and many other medicines we use to affect the immune system. So sometimes, say it's common in rheumatology, which is a specialty that deals with a lot of immune disorders, to overlap prednisone because it works faster to relieve symptoms, and add another medicine that works more slowly but has fewer long-term side effects. So that has been a strategy used in other immune diseases. I would say used less frequently in this condition, though certainly for acute episodes, it's one of the main reasons we use prednisone and other corticosteroids to treat an acute episode, even though we may still give rituximab. We're trying to suppress the immune system as fast as possible. We sort of will sometimes talk about bridging medicines, where you use a medicine that works fast at the same time we're starting a medicine with fewer side effects that takes longer to work.
Okay. For patients that have stress as a known trigger or have had relapses from stress triggering after a low Adams TS13, are there health style changes or more homeopathic remedies that you suggest? Specifically being asked about is CBD oil, but I know that we had talked about the importance of a healthy diet, the Mediterranean cardiovascular diet for that. So what would you guys recommend for these patients? Have you had an experience with CBD, or what would you recommend as far as keeping a healthy lifestyle?
I think this is one example of, we don't know a whole lot about other things that may work for this disease. We mostly can talk about things that have been well studied, and I think we just don't have any information is the answer. Just like nutrition, it's likely that there are nutritional strategies that may work, but we just don't know what they are yet. I take a similar strategy in that we know this is a blood vessel disease, so encouraging a heart healthy lifestyle is certainly very logical, but we don't know what the impact of those things are.
I think it's important to emphasize why we're not against supplements. We just don't know what to answer, because a lot, in addition to how well a drug works and if it's safe, the FDA also looks at how that drug is made and is it reproducibly the same thing. So one person's CBD oil in California may be completely different from New York and Texas, and some of it may not contain any CBD. So it's hard. The standardization of what you're getting is the biggest question. So two people might take the same, quote unquote, same thing, get a different response, and it might be because they're taking two different things, which is a difficult thing to understand sometimes.
It's a very strange thing about supplements in this country, that the FDA does not regulate them the same way that medicines are. And that's why you've heard people say, we just don't know what's in there, is that it's because they're not overseen the same way medicines are.
Isn't the responsibility that Marshall has to be safe, but as a supplement doesn't have to be effective, correct?
Right, it's a different
That's
standard,
where the responsibility lies. Yeah.
All right, in the last 5 minutes here, so does somebody want to talk about those consensus documents we published and kind of explain why we put those together and what their utility might be?
Marshall, I'm happy to. You want to take a shot?
Yeah, well, we hope they're helpful to people. We, I think, want to try to offer advice to hematologists and oncologists throughout the country on how we think that the disease should be treated. And that's based on people like us who do a lot of thinking about this disease. It's a rare disease that some hematologist oncologists may only see a handful of times in their life. And so the goal of the documents was to provide an easily accessed resource for those physicians who may not see the disease a lot and want some clarity on how to treat it, but then also a place where other physicians could reach out to us if they need help. So it's really just there as a resource for physicians around the country, particularly those who might not see the disease a lot and might need guidance on what the thoughts of the experts in the field are doing to diagnose and treat their patients right now. So the intent too is that this would be essentially a living document that's updated as treatments change and opinions change. There's lots of medicine that's opinion-based, experience-based. And so we wanted to try to include some of that. Medicine has guidelines, which are largely based on what is available from hard science, which is fantastic. But what that means is that a lot of the nuance of management of especially rare diseases where there isn't good hard science, decisions still have to be made. And so we wanted to try to offer some guidance in those grayer areas.
I think the key word is guidance. It's to help guide physicians and patients, but the specifics are really left to the discretion of the physician and the patient to discuss based on individual circumstances. But as Marshall said, we'd like to provide some guidance to physicians as how to handle and treat this disease in general. And again, to reach out to us if they have questions.
And where are these wonderful guidance documents located? Which one of the physicians can tell me? They are located on our website at ustmaconsortium.com.
Oh, thank you for the plug.
Yeah, no problem. And they are under TTP diagnosis and treatment documents. They're split into 3 categories: the diagnosis, the treatment, and then the outpatient management. So it's designed for patients that come in, first get diagnosed, they have their acute episode, they're being treated in the hospital, and then how they're followed afterwards, allowing us to kind of consolidate or create a semi-uniform way that patients are being treated by our consortium physicians.
And meant to be complementary to other existing
Yes.
TTP guidelines, not meant to contradict. And I think they're pretty much in step.
Yes.
Yeah, I think the main difference was methodology. Guidelines have a specific strategy, whereas our document includes well-established scientific-based strategies with some degree of expert opinion.
All right, we've got time for just 2 more topics. The acquired TTP patients in the recombinant ADAMTS-TS13 trials, they actually started the recombinant ADAMTS-TS13 trials with the recombinant patients, correct? That was the first clinical trial that they actually started. So
well, the first trial was done in congenital TTP.
Congenital,
They've
okay.
now moved into a trial in each.
Okay. And then if a patient's, just to one more time, drive this home. If a patient's IMS-TS13 is low and they know it's low, would you hold off on the vaccine, or would you move forward with a COVID vaccine and then monitor them to make sure that that wasn't a second hit? And define by what you would consider low, because I know there's different thresholds that people utilize.
Maybe I'll start, but I'm kind of curious to hear all of my colleagues, because it's really an excellent question without an answer. We don't know what the right answer is. Maybe there should be I think studies about to help answer that question, but it's going to be so hard to actually generate any kind of significant data because of the rarity of what we're talking about. The problem here is that if you have a low ADAM-TS13, in order to change that, and generally we try to modify it with rituximab, you're then committing yourself to at least 6 months of having a poor response to vaccination. So, the risk of having a TTP flare or some other problem from vaccination is so remote that I still think it makes sense to get vaccinated in that situation, and then have maybe monitoring of platelets post-vaccination as the best way, as opposed to waiting a long period of time before you try to get vaccinated, because 6 months or more can be a real problem during a pandemic.
I'd agree. That's exactly the situation you have to talk with your physician. That's certainly a unique situation where the level is low. And we're talking typically less than 10 or 20%, where we might be more concerned. So there's, as we've talked about, there's the potential for that. But there's also the potential for a COVID infection, which would likely trigger TTP episode more so than the vaccine would. So there's no easy answer. You got to consider both sides of the argument.
All right, and I will cut it off there. Anyone who hasn't had your question answered, feel free to email us or reach out on Facebook. admin@ustmaconsortium.com is the email address, and the Facebook page, you just message it in and we'll pass it along to our medical board. Thank you so much for everyone who joined us tonight.